Blaze, I think we're ready for you. Dr. Carabello is going to talk to us about pathophysiology of aortic valve disease.
Oh, gee, thank you. So 30 years ago, or 40, Bill Grossman suggested this paradigm for the development of hypertrophy, that increased systolic wall stress, increased pressure in the numerator of the Laplace equation, in some way informed the myocardium to generate sarcomeres in parallel so that each myocyte would become thicker, the wall would become thicker, and that increased thickness in the denominator of the Laplace equation would offset the increased pressure in the numerator. Wall stress or afterload would remain the same, and therefore ejection performance would not be affected. And you all know patients who, despite a 100 millimeter gradient across the aortic valve, have perfectly normal ejection fractions. On the other hand, some patients don't have adequate hypertrophy, and so that wall stress increases and ejection fraction is depressed. In still other patients, especially older women, there seems to be too much hypertrophy, so that wall stress is actually subnormal, and you see these nutcracker ventricles where the ejection fraction approaches 100%. And although their ejection fraction is high, these are scary folks because, as you all know, these are difficult ventricles to protect during surgery. So why this big difference in the amount of hypertrophy that develops? In this animal model, a dog model, where we were able to control the gradient across the aorta in a fairly precise way, we recapitulated what you see in our patients. Some dogs developed this incredibly severe hypertrophy, others didn't, despite exactly the same pressure overload on the ventricle. And of interest, the dogs that had the least amount of hypertrophy, the guys in the dark circles, always had the biggest signal. So despite a signal to develop hypertrophy, they developed less of it. And I think if each of you developed in the audience aortic stenosis, and I did, we'd all have differing amounts of hypertrophy, but because despite the signal to develop hypertrophy, we all have a dozen or more signaling pathways that are genetically controlled that transduce that signal into the amount of muscle mass that's developed, so that each patient almost has a unique pattern according to their genetics. I think we all recognize that LVH is a double-edged sword. While the increased mass allows the ventricle to generate the pressure to push blood across the tight aortic valve, it's also bad for you. Concentric hypertrophy imperils the subendocardium, and if you look at coronary blood flow in hypertrophy during pacing, it doesn't increase. The subendocardium in our patients with aortic stenosis is constantly imperiled by the risk of subendocardial ischemia when they exercise, one of the reasons they develop angina. And these ventricles are stiff. Interestingly, so that the dark circles here are the average patient with aortic stenosis with reduced diastolic compliance. After surgery, temporarily, the ventricles actually get stiffer. And you may have noticed sometimes that your patients, despite a great operation, are still dyspneic the month or two after surgery. And this is because the actin and myosin elements of the ventricle remodel very quickly. Your actin and myosin in each of you is only about 10 days old, and then it turns over. The collagen takes forever. And so that immediately after surgery, the amount of actin and myosin in the ventricle goes down, but the collagen stays the same, so that the percentage of collagen actually goes up. The ventricle temporarily gets stiffer until later on in the course of the disease, a year later, when further remodeling now, the collagen structures allow stiffness to return to normal. The Ross and Braunwald data are still quite true today. If your patient with aortic stenosis develops the symptoms of angina, syncope, or heart failure, they're going to die very quickly, but the age has changed. The average age in the Ross and Braunwald data was about 48, because those patients primarily had either congenital or rheumatic disease, typically today we're seeing patients with an atherosclerotic calcific aortic stenosis that forms much later in life, so that the average patient today is in their late 70s or 80s. But once they develop symptoms, they're no less deadly today than they were in the Ross and Brownwald era. As you all know, surgery is usually corrective, and even 30 years ago had a profound reduction in mortality. But there are still two groups of patients that are a pain in the ass. And those are those patients with low flow, low gradient, and low EF, and the patients with low flow, low gradient, and normal EF, and exactly what to do with them. Mark has already talked about this some. Here's a 77-year-old guy who's dyspneic with simply the normal activities of daily living, low ejection fraction, low gradient, and tight aortic valve, as opposed to the group of patients I showed you earlier where ejection fraction was reduced because of afterload excess. This group of patients has a reduced ejection fraction because the ventricle is shot. This is severe LV dysfunction causing a reduction in EF beyond what you would expect from afterload mismatch. And they all have an increased risk for surgery. Mark talked about the Monin data. Those patients who achieve at least a 20% increase in their stroke volume during dobutamine infusion have a pretty good outcome. About a 10% operative risk, not wonderful, but acceptable, and a relatively positive long-term prognosis. They do much better than this group treated medically, and they do much better than the group that fails to have inotropic reserve, where the operative risk is as high as 30%. A problem is that even this group that failed to have inotropic reserve still does better with surgery than they do with so-called medical therapy, whatever that is. And so that's a problem. You're confronted then with a group of very high surgical risk that might do better. And we heard about balloon aortic valvuloplasty as one way of segregating them. Another way are these data from Triboulet. There's low gradient and really low gradient. And for patients who can't even mount a gradient of 20 millimeters of mercury, the outcome is dismal, especially if the reason that ventricle is shot is because of multiple myocardial infarctions. Dead meat don't beat. You can't unload a scar. And so for these patients with exceptionally low transvalvular gradients, especially when they've had multiple MIs, I usually just advise them to buy their magazines off the rack. I don't believe that they are going to do very well with an aortic valve replacement. And here's the other group, an 80-year-old lady, looks like she has all of the features of severe aortic stenosis on physical examination. She's got a very thick left ventricle, maintaining a normal ejection fraction, but the ventricle is so thick that there's no room for the blood. And if end diastolic volume is small, the patient can't mount a stroke volume, and it's stroke volume that generates the gradient. So they then have a, if you will, paradoxically low gradient despite a normal ejection fraction. It really isn't paradoxical. It's just that it's a small ventricle that can't generate a stroke volume. These patients that Pibereau and his colleagues here from Quebec, that he's termed paradoxic low flow, paradoxic because their ejection fractions are normal, still have, in her case, symptomatic, severe aortic stenosis. And if you're convinced that's what they've got, they'll do better with surgery than they will with medical therapy, because after all, they have symptomatic severe aortic stenosis. So the LV's response to pressure overload is quite capricious. It's different in almost every patient because every patient has a different set of genes that transduces pressure overload into the amount of hypertrophy and the kind of hypertrophy that's developed. Hypertrophy is both compensatory and evil. It allows the ventricle to generate more pressure, but is also responsible for most of the symptoms and most of the pathology of severe aortic stenosis. And one size doesn't fit all, despite the fact that I'm one of the authors of the guidelines, and we've given you some guidelines for determining whether someone has severe aortic stenosis and what to do. Every patient is different. There's no cookbook approach to this, and every patient with this disease has got to be considered individually. Thank you very much for your attention.
Blaise, thank you. Let me ask you one quick question. That's about the asymptomatic patient with severe aortic stenosis. Is it calcification? Is it meters per second? What are we supposed to do when we have a young patient, bicuspid disease, really severe AS, really active?
Well, first of all, so if the patient is very active, I think that's a point toward early surgery. I hate to tell a patient, well, gee, what you really have to do is sit on your can and not do anything because I'm afraid you're going to drop over dead even though you're asymptomatic. And when I fly home today, I'd really be upset to hear that both pilots had a jet velocity of 4, even if they were asymptomatic. So I think what people do, what they demand from their valve is an important point toward early surgery. If you look at the way in which the guidelines have progressed, we are looking for earlier and earlier surgery because surgery has gotten better and better.
Are you at 4 or 5 for meters per second for velocity?
Well, but the last lady only had like 3. I don't think it's a specific jet velocity. I think it's the whole patient taken in the continuum. And that's why in the current iteration of the guidelines, we've tried to get away from that table that talks about mild, moderate, and severe toward a more comprehensive approach.
Okay, Blaise, thanks very much.